Our Vice Dean for Academic Affairs, Ibu Reza Savitri, SOS FSI PhD. Our esteemed Head of Department of Psychology, Ibu Dita Rahmayani, SPSI MA. Our esteemed Head of Program of Psychology Undergraduate Program, Dr. Ika Susilawati, SPSI MPSI. And our incredible guest lecturer, all the way from UCSI University Malaysia, Dr. Abbas Abdollahi. And of course, to all of our wonderful fellow lecturers and students who have joined us today. To ensure our virtual lecture runs smoothly, please keep a few rules in mind. The first one is please ensure your microphone remain muted during the welcoming remarks and the main presentation. And we highly encourage everyone to turn on your cameras to keep this session interactive and engaging. And if you have any questions during the presentation, you can type them into the chat box, as we will be holding 2 or 3 dedicated Q&A sessions right after the presentation concludes. And to officially open today's event, I would like to invite our Vice Dean for Academic Affairs to deliver the opening remarks, to Ibu Reza Savitri, SOS MSI PhD. The screen is yours. Ibu Reza, monggo.
Terima kasih Mbak Ratri atas kesempatannya. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi dan salam sejahtera bagi kita semua. Yang kami hormati Associate Professor in Psychology dari UCSI University, Dr. Abbas Abdollahi, kemudian Ketua Departemen Psikologi, Ibu Dita, KPS S1 Psikologi, Bu Cici, dan teman-teman dosen semua. Pada kesempatan yang baik ini, izinkan saya menyampaikan apresiasi yang sebesar-besarnya kepada Departemen Psikologi yang sudah menyelenggarakan kegiatan visiting lecture melalui program Adjunct Profesor. Merupakan sebuah kehormatan bagi kita semua ya, terutama adik-adik mahasiswa untuk dapat mengikuti sesi kuliah tamu bersama Dr. Abbas yang akan menyampaikan materi dengan tajuk Understanding Depression, Theories, Symptoms, and Psychological Perspective. Tema yang sangat menarik dan topik ini sangat relevan saat ini, terutama dengan perkembangan isu kesehatan mental di masyarakat modern ya. Isu-isu kesehatan mental, depresi dan lain sebagainya nampaknya melanda semua lapisan masyarakat ya. Jadi harapannya melalui sesi ini para peserta dan kita semua dapat memperoleh wawasan baru, mendapatkan perspektif akademik yang lebih luas, serta meningkatkan pemahaman kita semua tentang depresi dari sudut pandang psikologi dan ilmiah. Kami ucapkan terima kasih yang sebesar-besarnya kepada Dr. Abbas Abdollahi atas kesediaannya untuk berbagi ilmu dan pengalaman bersama kita semua. Semoga kegiatan ini dapat memberikan manfaat akademik sekaligus praktis bagi seluruh peserta. Akhir kata, saya ucapkan selamat mengikuti kegiatan kuliah tamu pada hari ini. Semoga acaranya berjalan lancar dan memberikan inspirasi bagi kita semua. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Ibu Reza Savitri, for those wonderful opening words and for officially launching today's visiting lecture. And before we transition to the main lecture, I would like to capture several documentation of this event with all our distinguished guests and participants. May I request everyone, including our Vice Dean, Head of Department, Head of Program, lecturers, and students, to please turn on your cameras for a quick group photo session. Benia will help me taking screenshots across the pages. Please, Benia.
Okay, thank you, ma'am. I will lead the photo session right now. For the first page, 1, 2, 3. Okay, then for the second page. Okay, 1, 2, 3. Okay, next for the third page. 1, 2, 3. Okay, next for the fourth page. 1, 2, 3. And for the last page. Okay, 1, 2, 3.
That's all, Benia?
That's all.
Okay.
Thank you, ma'am.
Yeah, thank you so much, Benia. Thank you so much, everyone. And you may keep your cameras on as we move forward. And now it is my absolute privilege to introduce our main speaker for today. Dr. Abbas Abdollahi is an associate professor in psychology at UCSI University, Malaysia. He holds a PhD in psychology from University Putra Malaysia and is a highly accomplished researcher specializing in mental health, psychometrics, and family psychology. And today, Dr. Abbas will be taking us through a fascinating journey in abnormal psychology, focusing on the theories of depression, tracing it all the way from its ancient historical roots to modern cognitive behavioral frameworks. And without further ado, Dr. Abbas, we are absolutely thrilled to have you, and the screen is yours.
Okay. Thank you so much. First, I have to appreciate you for inviting me, for sharing my knowledge to all you, and specifically thank you and appreciate Vice Dean Dr. Reza Safritri for introducing me, and all of the persons, Dr. Ika, you and others, to invite me. If you let me, I'm starting with my presentation about the depression and the theory and the symptom. Let me share my screen to you. Okay. First, as as I introduced, I am Abbas Abdollahi and I'm associate professor at UCSI. Today, I want to speak about the depression and about the about the most important and widely studied topic in mental health. And I'm trying in this workshop to start with the history of the depression and the major psychological theories and the most effective treatment about the psychologists. Let me starting with uh, Hippocrates. I think this person is very famous, and this is the um, very influenced person in the psychology. And as you know, he was born around 460 before current era and the Greek island of Chaos. And what makes Hippocrates specifically important is that because he separated medicine from religion and superstition, and this is too important. And he said he sees illness as a he didn't see the illness as a punish from the God. He purposed that the disease have a natural causes. And this is very important because this is a major shift in thinking. In that time, the the people thought that if the people involved in the disease, they are a punishment from the gods, or this is related to the some superstitions. And the Hippocrates helps to us to find the natural causes for the disease, and this is too important, and this shifting is very helpful for the scientific society. And now let me to start from uh, the four the theory of the four humors, and this is too important because the theory we are speaking about the four humors about the people. According to this theory, the health depends on of the balance of the four bodily fluids: blood, fluid, yellow bile, and billow bile. Each of these was associated with a specific personality type. For example, people dominated by blood were considered sanguine. The characteristic of sanguine is cheerful and energetic. Those with more folic were seen as a calm and unemotional. So now, if I want to speak about the humors, I have to say that individual with a high level of blood, they are very cheerful, they are very energetic, and they are involved in the sanguine humor. If when we are speaking about yellow bile, they are very ambitious but easily angered. And when we are speaking about black bile, it's associated with melancholic temperament characterized by sadness, fear, and withdrawal. This last type is particularly important because this term, meaning that mean melancholia, was historically used to describe what we now call as a depression. Although this theory is not longer scientifically valid, it was one of the earliest attempts to explain mental health in biological terms. So when we when we are speaking about melancholy for the first time, meaning that we are speaking about the depression, but in that time Hippocrates speaks about the melancholy, and the characteristic of the melancholy is same as the symptoms of the depression in the DSM. So we all in depth of the Hippocrates for the four humors that provided for us. Now we want to summarize this slide again for you. So based on the Hippocrates, we are four humors: sanguine, phlegmatic, choleric, and melancholic. So about the sanguine, people are involved in cheerful, optimistic, energy, and temperament. Individuals with a high level of phlegmatic are experiencing calm on emotion and stay dispositions. Okay. An individual with a high level of choleric, they are ambitious and they are a little bit unhappy and they are feeling of anger. And the last one is black bile, an individual with a high level of black bile involved in melancholic. Melancholic meaning that individual has a characteristic like depression characteristic. They are they are sleeping in the short time. For example, they are sleeping at the early of the morning, and they are aversion of eating. They don't like to eat food. They are losing the weight. So when you see the individual with the losing the weight, they don't have interest to involve with others, and they would like to be alone, and they reduce the weight, that, and these persons are involved in melancholy based on Hippocratic perspective. So you see the people with such characteristic involved in melancholy. In this PowerPoint, you understand that the Hippocrates believe that the melancholic, meaning that individual with a high level of black bile. An individual with high level of black bile involved in melancholy, they are feeling of loneliness, they are feeling of the feeling of restless, insomnia, aggressiveness. So these type of behaviors are seen in individual with high level of black bile, meaning that melancholic individuals. So individual, and in these individuals are feeling of hopelessness, meaning that they don't have any hope for the future. They believe that they are not good enough, and they are avoid to eat food, meaning that they don't have good. They don't have starving to eat food. They are not feeling to eat food. They are losing the weight. They are involved in insomnia, and such individual showing that the aggressive and violent behavior to others, and this type of behavior showing that this individual involved in melancholic characteristic. An individual with melancholic characteristic um, are more likely to drink alcohol and are more likely involved in the law. So these are a characteristic of the melancholic individual based on the hypocrite's perspective. And they are there are several types of the treatment for the melancholic individual based on hypnotics perspective. So just I'm ignoring about it because these are maybe just these are related to the treatment, and the majority of treatments are not acceptable for the science, for the nowadays science. For example, uh, he believes that they can be remedied by the herbal, they can be remedied by the warming food, meaning that they can remedy by the, you know, regular sleeping, they can remedy by the eating the fresh food, the fresh food and fresh fruits. They are a remedy from the hypocrites for the melancholic individual. And the hypocrites believes that individual involved in melancholy, it's better going to the relaxed environment. So we believe that the hypocrite is a very smart person, because he believes that and emphasize about the role of the environment in the treatment of individual. And he believes that individual with melancholic features and melancholic characteristics are treated by listening to the music, going to take a shower, warm bath, and pleasant surroundings, meaning that if the environment are okay and are providing the good facilitating for the melancholic individual, the the symptom of melancholics are reduced. So we understand that hypocrites emphasize on the role of the environment in reducing of the symptom of melancholic features. And this is too important. So in this slide, you see that the hypocrites uh, stated about the symptom of melancholic individual. When we are comparing the symptoms that mentioned by the hypocrites 2,400 years ago, and with the DSM about the symptom of the depression, we understand that hypocrites very smart, because when we see the list of the melancholic features are restless, aggressiveness, insomnia, hopelessness, aversion to food, and alcohol and love. Now, when we are considering the DSM and when we are considering the symptom of depression in the DSM, we see that the majority of the symptoms mentioned by the hypocrites are stated in the DSM. So we have to believe that hypocrites are very famous and very influenced person about the history of the depression. Okay, now now we say that when we are about the black bile, because the black bile is the fluid of the black bile is high in individual with melancholy, and you understand that not only the body of the person is involved in the black bile, you understand that there is a corruptions in the brain activities, and you understand that the people are involved in the persistent fear, the sadness, and the distorted perception. It means that the the biology and the neurotransmitters in individual involved in melancholy are damaged. But this is very important when we are speaking nowadays about the brain and neurotransmitter in the individual. We understand that the some neurotransmitters in individual involved in depression are damaged, such as that the serotonin, the serotonin is the amount of serotonin in individual involved in depression is low. So we understand that the root of neurotransmitter perspective about the depression is related to the hypocrites, and we understand that the influence of the hypocrites of the history of the depression, and this is too important. Okay, and based on the hypocrites, he believes that the individuals are more involved in melancholy in the autumn season with a poor diet, prolonged greed, and the physical exhaustion. And he believed that when individual with low level of black bile, the individual with a high level of black bile, pardon me, and are involved in melancholy, they are feeling of fatigue, they are feeling of burnout, and they don't have a good mood, and they don't have a good energy. So when we are speaking about the depression in DSM-4, we understand that yes, the root of the symptoms in DSM is related to the hypocrites, and very interesting. I think for me and for maybe for you, this is too interesting. Okay, and in this slide, the hypocrites divided the treatment for the melancholy, because saying that the individual can be treated by the food as a medicine, yeah, or elaborate plan or rest and calm that I told you about, like the black bile is high in individual, and they are using the specific food, meaning that the warming food and the warming food can help individual involved in melancholy to be treated. And the next one about using the some herbal plants. This is very interesting, because for the first time we are using the herbal treatment to treat the depressed individual. And the last one, the hypocrites speaks about the role of environment, patients involved in melancholy, in invited to rest, and that encourage them going to the pleasant surrounding, listening to the music, or take a warm bath, and avoiding the stressful situation. When we are considering some treatments from the hypocrites, we understand that the root of the majority of treatments nowadays are related to the hypocrites study. All right, okay. This one is the summary about the Hippocrates, the legacy of Hippocrates taught, melancholy studied and debated for over 2,000 years ago. And you understand that the symptoms of the depression nowadays are related to the study about more than 2,400 years ago, in that done by Hippocrates, and influenced Galen, Ibn Sina, and early Islamic medicine, and today remain major depression disorder. And we observe this name of disorder in DSM, so we understand that it's related to the study of Hippocrates. Okay, now at the first stage, I lecture to you about the Hippocrates and about the four humors to you, and the last one is melancholy is related to the depression. Now we want to speak about the modern perspective or modern classification. Now we want to speak about the era of crippling, because the pre-crippling era related to 1899. Before Emil Kriplin's landmark classification, mood disorders were described using a range of overlapping clinical terms, such as capturing a different facet of what we now recognize as the bipolar depressive disorder. So the categorization are mania, melancholia, cyclothymia, and circular insanity. So if I want to speak about mania, the characteristics of mania are elevated mood, racing thought, and excessive energy. You understand that individual involved in mania has a high level of energy. They are sleeping a little, they are doing the activity, you know, that they are thinking about several things, they are racing thoughts, several thoughts are attacking in the brain of individual involved in mania. And the next one is related to melancholia, the persistent sadness, meaning that the individual is not happy. They are experiencing of sadness, and they don't have enough hope for the life. They are hopelessness. They don't have enough energy to do the activity, and they are withdrawal from the life. And the third one is cyclothymia. Cyclothymia meaning that the individual is recurring swings between the elevated and depressed mode, meaning that sometimes they are experiencing the mild depression, sometimes individual experiencing the mania, meaning that the individual involved in cyclothymia, and circular insanity, alternating episode of mania and depression, a precursor to bipolar disorder. You know, when we are speaking about the circular insanity, nowadays we name it as a bipolar disorder. So if I want to conclude this slide, we can say that the pre-crippling era, the disorders are categorized as a mania, melancholia, cyclothymia, and circular insanity. So if you were a student at the pre-crippling era, just you have to memorize 4 categories: mania, melancholia, cyclothymia, and circular insanity. Okay, now we want to speak about the about after 1899 era, meaning that the crippling revolution. In the last slide, I'm speaking about the pre-crippling revolution. Now we are speaking about crippling revolution. In this era, the crippling provide the category for mania depressive insanity. In that time, as you remember, you know, when we are coming here, you know, there are 4 categorizations. mania, melancholia, cyclothymia, and circular insanity. But after Kriplin, he'll be saying that, yes, we have a disorder with a combination of mania and depression. So we understand that this is the new categorization for the depression. Emil Kriplin unified mania and melancholia. In that time, the mania is different and the melancholia is different. But after 1899, we understand that the mania and depression are combined and unified together. In that time, as you remember, when we are speaking about the schizophrenia, he distinguished mania depressive from dementia precox. The dementia precox is named by Philip Pinel, you know better than me. And in that, before this era, there is no categorization. When you see the racing thought, when you see the high level of energy, when you see the sadness, and when you see the hopelessness as a symptom, you understand that you categorize individual as a dementia precox or schizophrenia. Nowadays we call it as a schizophrenia, but in that time there was no classification for this. Crippling provide the classification for depressive, mania, depressive insanity. And this is a new categorization in the history of psychology. His longitudinal clinical observation tracking patient over years replaced a speculative hormonal theory with systematic empirical psychiatry. Okay, now we want to move to DSM era. Before explaining about the DSM, about the depression, just I want to conclude about the previous slides. As I told you, the Hippocrates as the pioneer of the depression, and he called depression as a melancholy. He believed that if the balance between the bodily fluid is changed, individual involved in disorder. And he provided four humors on an individual, and the melancholy is related to the depression we call nowadays as a depression. And after that, we are going to the pre-era crippling, meaning that the disorders, mental disorder, categorized in four sessions. In four sessions, the first one is mania, the second was melancholia, and the cyclothymia, and the circular insanity. After that, after 1899, and this is the era of crippling, meaning that the crippling separated the symptom of schizophrenia or with depression, and combine depression with mania and provide the new classification as a depressive mania, depressive insanity. Now, if now I want to move to the current classification of the depression. Now, so the first session is finished, because in the first session we speak to you about history of the depression that I told you about the Hippocrates and about the pre-crippling and the crippling era. Okay, now we want to review the DSM era. When you see in the DSM-1 and the DSM-2, it's from the 1952 to 1960. They call depressive neurosis, depressive viewed as a reaction to the life stress. Psychoanalytical framing dominated clinical thinking. As you know, the DSM-1 and DSM-2 was influenced by the psychoanalytical viewpoint, and they believe that the psychoanalytical viewpoint is more suitable to explain the depression. When we move to the DSM-3 and DSM-4, and the year is from 1918 to 1994, the depression is called as major depression, and they are going based on the symptom, and they believe that yes, we have to more focus on the symptom, meaning that we have when we see the symptoms, when you collect some symptoms, you can call this disorder as a depression. Let me explain to you about the symptomology and the etiology. In the DSM-1 and the DSM-2, the you understand that they are speaking about the etiology of the depression. For example, when you lose something, objective lose, based on the Sigmund Freud theory, you understand that the individual feeling of depression. Now we call it as a etiology because we want to know that what is the reason individual involved in depression. Okay, this is called etiology. In the DSM-3 and DSM-4, we are speaking about the symptomology. What's the meaning of the symptomology? When you see individual lose or gain the weight, when you see insomnia or hypersomnia in individual, when you see the hopelessness, when you see the think of killing oneself or suicidal ideation. When you're gathering the symptoms, you call these symptoms as a specific disorder, such as depression. Okay, but then you understand that the switching and changing from etiology to symptomology, from the DSM-1 and 2 to DSM-3 to 4. Now we move to DSM-5. DSM-5 is 2032. I think the last revision is related to 2024. And you understand the categorizations of the depressive spectrum. They understand that there is no one category as a depression. There is a depressive spectrum, and they call major depression disorder MDD, persistent depressive disorder, disruptive mode dysregulation disorder, recognized as a distinct condition. Now, let me summarize this slide and moving to another slide. Now, in this slide, we review the DSM era from DSM-1 to DSM-1 and 2 to DSM-3 to 4 and DSM-5. Now we are in the DSM-5. So we understand that the movement of categorizations of the depression during the DSM. In the DSM-1, the depression is influenced by the psychoanalysis perspective. In DSM-3 and 4, we are more focused on the symptomology. We understand that the psychiatrists are influenced in the DSM-3 and DSM-4. In the DSM-5, we are speaking about symptomology and etiology, but more focused on the symptomology. And we are seeing the new categorizations of the different types of the depression. Now we want to speak about two perspectives about depression. Okay, this is too important because when we are speaking about the symptoms of depression, we refer back to Martin Roth and Aubrey Lewis because they are more influential persons about DSM-5 to diagnosis of depression. You know that when we are speaking about Martin Roth was born in 1925 to 2006. They believe that an anxiety and depression are distinct, separated disorders with different symptoms. You know that Martin Roth believed that the symptom of anxiety and the symptoms of depression are distinct and separated from each other. We cannot say that they are the same. They are different. For example, the symptoms of anxiety is totally different from the symptom of depression. This is the belief of Martin Roth. Okay? But when we are speaking about Aubrey Lewis was born in 1900 to 1975. He believes that anxiety and depression are one unified illness, a continuum. He believes that Lewis believes that there is no distinct between anxiety and depression symptoms. When you individual involved in anxiety and when you individual involved in depression, they are a similarity and comorbidity in the symptoms of depression and anxiety. So he believes that no distinct between anxiety and depression. Maybe there is a question in your mind why I'm speaking about Martin Roth and Aubrey Lewis, because in the DSM-5, we are speaking about the features of depression. One of the features of depression is major depression disorder with the feature of anxiety. So we understand that. It's related to the influence of two scientists, Martin Roth and Aubrey Lewis, in the DSM-5. Okay, so this perspective is too important to understanding the symptoms of depression in DSM-5. Okay, now we summarize my teaching so far, and then move to the symptom of major depression disorder. So far, at the first of my lecture, I'm speaking about the hypocrites. Hypocrites identify depression as a medical condition, not as a moral failing or dive punishment. Okay, hypocrites believe that if the bodily fluids in individual is unbalanced, individual involved in problem. If you see the high level of black bile, individuals are more likely involved in melancholic. Okay, in pre-crippling era, we see the categorizations in four types. The first one is mania and the melancholy, and then cyclothymia and circular insanity. After the era of crippling, we see the new categorization. The crippling combine and unify the depression and mania together and provided mania depressive insanity. But it's different from mania depressive disorder, called as an insanity. Okay? After that, the crippling provide the distinguish between the mania depressive insanity with schizophrenia. So we understand that we are closing to the DSM. After that, we are speaking about the DSM era from DSM-1, 2 to DSM-3 and 4 and DSM-5. Now we are in the DSM-5. So now at the first session, I'm providing the history of the depression for you from the first, starting with hypocrites to now that called it as a DSM-5. Now let me moving to the categorization of the depressive disorder in DSM-5 revision. You see, there are categorization of depression, and there are as a disruptive mode dysregulation disorder and persistent depressive disorder, substance medication include depressive disorder, other specific depressive disorder, major depressive disorder, premenstrual dysphoric disorder, and depressive disorder due to another medical condition, unspecified depressive disorder. So this is the latest categorization of depressive disorder that I provided in this slide to you. Okay, before I'm explaining to you about major depression disorder as a depression, we want to speak about some models that explain the depression to you. Okay, there are different, 5 major explanatory models. Let me explain to you. When you are going to see the client involved in depression, you have to evaluate your client in different categorization based on the biology, based on the cognitive model, based on the psychodynamic model, behavioral model, and biopsychosocial model. So now we want to more focus on each of them for you. I believe that it's better to start from the psychodynamic model and then going to the cognitive model and to the behavioral model, and then at the last time going to the biopsychosocial model. I think all of them, all of us know Sigmund Freud, and he was born in 1856 and died in 1939, and he's from the Vienna. Now we want to justify depression based on the Sigmund Freud perspective and viewpoint. The first one related to the objective loss, a real or simple loss of the loved person, idea, or identification with whom the ego was bound. Let me explain to you what's the meaning of objective loss. When you see the client missed loved person, maybe the loved person is died, maybe the person is in the process of break up in relationship, meaning that the loved person is not here. Maybe it's related to the breakup, maybe it's related to passed away of the person, and something like this. You understand that individual involved in objective loss are objective loss, and individual are predisposition for depression, okay, based on the Sigmund Freud. And in my opinion, nowadays, when we are seeing individual in the grid, meaning that missing someone in life, the individual are involving in depressive symptoms. I think you are agree with the Sigmund Freud. Okay? So this is too important when, for example, when you have a client and when you ask your client why you are not good and why you are experiencing the depressive symptoms, and the client tells you that, yes, I missed the loved person in my life, maybe the father, maybe the mother, maybe the child, or maybe the loved person. So you understand that this individual involved in depression. For the second one is ambivalence and introjection. The last object is taken into the self. Love and unconscious anger toward it are not directed at the ego. Let me explain to you. You know, the most individual in the world experiencing the love maybe the love between man and woman. And when you are in the love, maybe you are not completely satisfied from your partner, meaning that you love your partner, but maybe you are some anger toward your partner, but you cannot say your anger to the partner. In such situation, it's more likely to inward the anger. The anger is going to inward, and the sign of the anger is going to the inside of you. So in such situation, you are experiencing depression. Let me explain to you. For example, you are a psychologist and your client is a woman, and the woman is coming to your treatment room. You ask to your client, what is your problem? Saying that I love my partner, but I'm not satisfied 100% from my partner because some behaviors of my partner are annoying me, and now I'm feeling of sadness. Based on the Sigmund Freud interpretation, this case, experiencing the ambivalence between love and anger and introjected anger to oneself, to the ego. Okay? Okay. Do you understand that the reason of depression related to the ambivalence of love and anger in individual based on the Sigmund Freud? And the last one is self reproach, hostility, defected unto the self produces guilt, worthlessness, and punitive superego. Let me explain. You know that the structure of the mind based on the Sigmund Freud categorizes in three parts: id, ego, and superego. Okay? Let me explain to you and let me repeat it again. When we are speaking about the structure of the mind based on the Sigmund Freud, we have to speak about id, ego, and superego. Okay? But based on the training of the parent and the environment, you understand that some people have a double superego. Double superego. When you see individual with a high level of superego relative to the ego and id, in such situation, individual are more likely to experience depression. The client is coming in your treatment room. You say, what is your problem? Saying that I break up from my partner, but I'm feeling of guilt. I don't know he or she can care about oneself. I think I didn't have pleasant behavior to him or her. I'm feeling of guilt. And I have to punish myself. When you are hearing such sentences from your client, you understand that based on the Sigmund Freud, your client has a double superego. And the double superego provides for your clients to feeling of guilt and experiencing of depression. Okay? This is a justification based on the Sigmund Freud. Let me make a conclusion about this slide. In this slide, I'm trying to explain the depression based on the Sigmund Freud perspective. The first one, object loss. The second one, ambivalence. The third one is self-reproach, meaning that individual punish oneself based on the double superego. Okay, let me move to the next one. And this is related to the John Bowlby. John Bowlby is from London. He was born in 1907 to 90 and died in 1990. I think all of you familiar with the John Bowlby theory, because the John Bowlby theory is related to the attachment bond. But I think maybe this is interesting to you. I'm explaining about the history of the attachment bond of the Bowlby theory. In 1939 is the era of World War II, and there is a war between United Kingdom and Germany. In that time, Hitler, as a prime minister of the Germany, decided to attack to the London. And Churchill, as a prime minister of the United Kingdom, decided to transfer all children from London to the village around of the London city. Around 7,350 children transferred from London to the village around of the London. When the children moving from the village, they are caring in the institute. One day, and there was a rule, during a month, the parent allowed to see the children one time in the one side sign room. Children were playing in the room, and the parents were outside the room and watching the children. One day, the wife of the Russell is a famous author, lately went to the institute to see her children, and the person in charge told to the Russell's wife, "The time is over. You can't see your children." Russell's wife back to the London and complained to the Russell about the bad behavior of the person in charge. Russell was a more famous than John Bowlby, an author, and write something on the newspaper. John Bowlby read the Russell's text on the newspaper and went to see the Russell and saying that, "I believe that the next generation in the London, in the United Kingdom, will encounter to the problem because they are involved in insecure attachment styles." This is the history of the John Bowlby attachment bond theory. So, with the help of the Russell, John Bowlby disclosure his theory to the people and to others, I think John Bowlby in depth of the Russell, because Russell in that time was more famous than John Bowlby, and John Bowlby got the help from the Russell to develop his theory. This is the history of the attachment bond based in World War II. Now, let me explain it to you about the attachment bond. As you know, we are two types of the attachment styles: avoidant attachment style and anxious attachment styles. When early lose and from the first one, early lose and separation, prolonged separation from or unavailability of a primary caregiver evokes protest, disappear, and detachment, the development template for depressive state that I explained to you when I explained to you about the history of the attachment bond of John Bowlby theory. You understand that the meaning of early lose and separation. I want to request you to think about it. When I'm explaining about the Sigmund theory, this one, just I'm speaking about a person, such as object lose, ambivalence, introjection, and self-reproach. In the Sigmund theory, we are speaking about a person. In John Bowlby theory, we are speaking about relationship. Do you understand me? You know, in the John Bowlby, we are speaking about a child separated in the early time of the life from the parent. Okay? So in this theory, we are speaking about the relationship between individuals when we want to compare the John Bowlby theory with the Sigmund Freud theory. And you know that the repeated insecure interaction encode themselves as unlovable and others are unreliable. Schemas that bias adult appraisal and emotional regulation. You know, when you abandoned from your parent, such as the children abandoned from the parents in the London, they believe that yes, I am as a child is unlovable child. I am not lovable child. And my parents is unreliable. Maybe in the future they are not available for me. They are feeling of depression because they cannot believe that yes, the world is trustable and I can to trust others. You know that. In the last one, insecure attachment at risk. Anxious attachment predicts depressive symptoms via rumination and fear of abandonment. Avoidant attachment via affective and social withdrawal. Let me explain to you by one case in clinical. For example, you have a client and the client is woman. And you ask the woman, why you have not married so far? Maybe the woman replied to you, I'm worried. I'm worried going to the relationship because when I see the relationship between my father and my mother, and they are in tribunal, and they don't have a good relationship together because I'm avoiding going to the relationship because I want to keep safe myself. You understand that the attachment type of your client is avoidant attachment style. Based on John Bowlby, the root of depression is related to the relationship, and the person is avoiding going to the relationship with someone else. Let me explain about anxious attachment style. When you are seeing your client control and monitor of the partners, saying that, for example, can you send me your location while you are flirting with someone else, while you are behave like this, while you are laughing with opposite sex? Sorry, do you hear me? Okay, because I think the microphone is on and I think that someone asked me a question.
Yeah, I think there's a noise coming from somewhere, but I'm not sure where it came from.
I don't think so. Okay, now can I continue?
Yeah, please.
Okay. Have you seen my PowerPoint?
Yes.
Okay. Okay, now about anxious attachment style. You are seeing the individual are involved in an anxiety about missing the partner. An individual in such situation are more likely experience depression. Okay, let me conclude about this slide to you. John Bowlby speaking about attachment style and he believes that the root of depression is related to the quality of the relationship with another person. Okay, so the root of the depression based on the John Bowlby theory is related to the relationship between individual. And if individual with maladaptive attachment styles are more likely experience depression, such as anxious attachment style and avoidant attachment style. In the Sigmund Freud, we are speaking about person. Now let me move to the three thinkers who reframe how we see depression. The first one, I think, Aaron Tibet, and I think this is very familiar because when I speak with Dr. Ika said that the CBT is one of the important theory in the university. Okay, the developer, let me speaking about Aaron Tibet as a developer of CBT, and now we want to interpret depression based on the Aaron Tibet perspective. As you know, Aaron Tibet passed away, I think, 5 years ago. He was born in 1921 and he passed away 2021. I think 100 years he lives in the world. Okay, and I want to speak about this one. Now move to the three perspective. The first one is negative view of the self. What does mean of negative view of the self? Some people believe that I'm not worthwhile, I'm worthless, I'm not. Sorry.
Yeah, I think there's some kind of sounds coming from. I'm not sure because the part is. Teman-teman boleh di mute nggak? Tapi nggak ada ya. Siapa yang?
Can I continue?
Yeah, please.
Okay, you understand that individual is not good enough and believe that I'm not good enough, and I'm thinking that I'm worthless and defective and feeling of inadequacy. This person has a negative perspective to the self. And the second one is negative view of the world and believe that the world is not a safe place, and believe that I'm not feeling of comfortable in the world because the world is not a safe place and the world is not a fair place. When you are feeling about unfairness of the world, you have a negative view of the world, and in such situation, individuals are more likely to experience depression. And the last one is negative view of the future, and meaning that individual doesn't have enough hope about the future, and they believe that mm, they are suffering from the hopelessness, and they believe that they cannot be successful in the future, and mm, they believe that they don't be a victory gain in the future. So when you see the individual with a negative view of the self, or negative view of the world, or negative view of the future, or maybe the individual has a three negative aspects, maybe negative view of self, world, and future. In such situation, individuals are more likely experience of depression. Okay, and this is too important. So when we are speaking about diathesis stress theory, meaning that the individual, if involved in depression, please be careful about this theory. You see the individual with depression, okay? There is a question in your mind. Why some depressed individual involved in depression commit suicide, but someone don't commit suicide? Based on the diathesis, stress hopelessness theory, believe that if individual involved in depression with high level of hopelessness, it's more likely to commit suicide. Let me explain to you. Your client is depressed, and your client currently lose the job, and your client your client has a problem about daily expenses of the life and thinking about suicide. If your client doesn't have any hope about future or getting the job, it's more likely your client commits suicide. Okay? Let me compare another client for you. Your client is depressed and currently lose the job, and your client has a problem about daily expenses, but your client have a hope. Your client tells you that my father tells me I'm finding the job for you. My friend promises me to find a job for me. When you see the social support, when you see the hope in your client, you can think it's less likely your client commits suicide. This is called diathesis hopelessness stress theory. And this is too important. Maybe in the future you will have a client involved in depression. How do you estimate your client involved in depression commit suicide or don't commit suicide? Based on the hopelessness diathesis stress theory. when you evaluate your client and you understand that your client has a hope, it's less likely your client commits suicide. But when you evaluate your client and you understand that your client doesn't have a hope, it's more likely your client commits suicide or think about suicide. So this is a hopelessness and helplessness theory that I explained to you. Okay, the next theory is about the internal, global, and stable. When something bad happens, depressed individuals tend to explain it along three dimensions that look the experience in place, making failure feel personal, universal, or permanent. I think you are familiar with this. When there is a failure and you contribute the failure to internal and global and believe that yes, this program is global. And when you say that the problem is stable and you understand that your expectation is the problem is persist into the future, it's more likely to experience depression. For example, when you see the individual involved in jobless and believe that yes, this problem related to myself, it's not related to the situation, saying that I don't have enough ability, I'm not good enough, because related to internal. When you understand that there is a problem in your client and your client generalize the problem to many areas of life, and you understand that your client doing the problem globally. And if you see your client see the problem stable, you understand that your client are more likely to experience depression. Okay, let me conclude this section about the Beck theory. And the first one is about the hopelessness theory about depression, and the next one about the negative view of the self, world, and the future. And you know, there are several cognitive errors that happen about negative view about self, others, and future. And in the next sessions, I'm speaking about some techniques about how to address the negative views about self, world, and the future. And the next theory is about hopelessness that I explained to you. And when you see individual without hope, you understand that individuals are more likely to commit suicide and involved in depression, because hope is one of the important factors. And if you see your client, you have to evaluate the amount of the hope. If you see individual with a low level of the hope, you have to understand that such individuals are more likely involved in depression and suicide ideation. And the next one is about internal and global unstable. When you see your clients see the problem as internal and global unstable, it's more likely your client involved in depression and maybe commit suicide. Whenever. Sorry. Okay. Can I continue?
Yes, please, Dr. Abbas. Valencia, tolong di-mute ya.
Okay.
Okay, thank you. Please.
Okay, now we want to speak about the theory about Martin Seligman. You know that the Martin Seligman as a positive psychologist, and now we want to speak about Martin Seligman's theory called as learned hopelessness. And Now we want to interpret the depression based on the learned hopelessness. When you are in the problem, based on the Martin Seligman's theory, when you are in the problem and you don't have any control on the problem, you are more likely involved in depression. Let me explain to you. When you see your client and your client saying that, yes, I get my bachelor, I get my master, I get my PhD, but now I don't find the job. In such situation, individual is more likely involved in depression because the person doesn't have any control about the problem. So when you see individual doesn't have any control on the problem, stressful situation, in such situation, individual is more likely involved in depression, meaning that when you effort a lot, but there is no change in the outcome, this is called learned hopelessness. Let me explain with your client. Maybe you have a client and your client is a wife, and the wife coming to you and complains about her husband, saying that I have to do everything to improve the quality of our life, but I don't have a good relationship with my husband. I don't know how I solve the problem. I'm feeling of hopelessness. In such situation, the wife is more likely involved in depression because the wife is effort a lot without any good outcome. And the wife doesn't any control on the husband's behavior because based on the wife's effort, no changes in the husband behavior. Individual involved in learned hopelessness. Let me think. I provided one video here, I think.
In this case, you're talking about how...
This is that video. Maybe it's not here. Just, I wanted to show you the experiment of Martin Seligman about learned hopelessness. I think all of you are familiar with the experiment about the dog in the plate under the shock and under the electronical shock, and the place is without electronical shock. And when you see the effort in the dog, when there is a shock in the plate, the dog moves to another place without the electrical shock. But sometimes Martin Seligman changes the positions. For example, put the shock in the one plate, and when the dog jump to another plate, again provide the shock in another plate. And you see at the first stage, the dog efforts a lot. But after that, when the dog understands that the effort doesn't any outcome, you see that the dog's laying down on the plate without any reaction. And the Martin Seligman increased the level of electrical shock in two plates, but there is no effort from the dog, meaning that the dog involved in learned hopelessness. Please be careful when you have a client. Provide the outcome for your client based on your client's effort. If you are a teacher, if your students are studying very good, please provide a positive feedback for them. If you are discriminant about between your student, for example, one student is studying more and one student is studying less, but you have the same behavior with both of them, I think this is not a good behavior, because the student, the smart student and the hard-working student believe that I'm studying more, but my teacher behaves with me like the student with low level of hard working, meaning that this discrimination provides the learn hopelessness for your student. So this is too important. So this theory is a very good theory. When you have a client involved in depression, you have to ask your client, why are you involved in depression? Maybe your client is saying that I'm effort a lot, but I don't get a good result. So you have to tick in your brain the problem of my client, meaning that the depression in my client related to the specific theory. What's the name of the theory? Theory related to the Martin Seligman called learned hopelessness. Okay, and this is related to when effort no longer matters. This is related to Martin Seligman. And the last, and this one is related to the Peter Levinson. I think Peter Levinson is speaking about reinforcement model, depression as a problem of too few rewarding consequences. For example, when you effort a lot, but you don't get the reinforcement. Let me explain to you. Two staffs are working in the office. Okay? One staff is working and get the good reinforcement from the boss. Another staff is working good, but the staff doesn't receive any good reinforcement from the boss. After that, this staff is experiencing frustrated and experiencing depression based on the Peter Levinson's theory. Believe that if you don't provide the good and suitable reinforcement for your client is more likely involved in depression. For example, I have heard from one of my clients saying that I afford a lot in my life, but my husband doesn't admire me, doesn't respect me. I have seen my sister's behavior. My sister's husband respect and admire my sister, but my husband doesn't do this. I don't get the good reinforcement from my husband when I see the behavior of my sister's husband with my sister. When we are speaking about reinforcement model, meaning that individual compare own self with others, and when they understand that they are not reinforced and encouraged, they are feeling of depression. Okay? Now, Peter Levinson speaks about too few rewarding consequences. One is lack of appropriate reward. What does mean of lack of appropriate reward? Meaning that the environment simply does not deliver enough pleasant consequence. Okay, such as examples I provided for you. And the next one is non-contingent reward. Reward arrive independently of the person's action. The link between effort and outcome is broken, so behavior is no longer a strength and gradually drops off. Okay? These concepts are from the Peter Levinson's, and when you have to be evaluate and you have to provide for your client appropriate reward and contingent reward. Both of them are too important based on the Levinson. Let me let me review some theories about explaining and interpreting depression. I started from the Sigmund Freud and the problem related to the person, the meaning of such as objective loss, ambivalence between the love and anger, and self-reproach, meaning that the people involved in double superego. And the next one is about John Bowlby. It's about the relationship. If the quality of the relationship is not good, individual is more likely to experience depression. And the next one is about Aaron Tibek and about the cognitive behavioral therapy and about the negative viewpoint about self, about the world, and about the future. And the problem is stable and global and internal. And the next one, the theory about the Martin Seligman, is about the learned hopelessness, meaning that individual doesn't have any control, and when they afford a lot, doesn't have any control about of the output. That I explained to you by some examples to you. And Peter Levinson's about the reinforcement model when you have a problem and when you don't receive a good reinforcement from the environment, meaning that you are more likely involved in depression. And Peter Levinson speaks about two types of the reinforcement: appropriate rewards and contingent reward. If there are a problem in two types of the reward, individuals are more likely involved in depression. Okay. Let me. Okay. Now we want to refer back to the five major explanatory model. I explained the sum theory regarding to the cognitive model, psychodynamic model, behavioral model. Now we want to speak about the biological model. As you know, at the first of this lecture, I spoke about the Hippocrates theory regarding to the bodily fluid, humors, and when there is imbalance with the bodily fluids, you understand that the individual involved in depression. There are three neurotransmitters play an important role in depression. When you see the low level of serotonin and dopamine and norepinephrine in your clients, meaning that your individuals inherently disposition for depression. So the level of serotonin and dopamine and norepinephrine are so important in experiencing of depression. And sometimes you understand that there are hormonal dysregulation in your client, and you understand that your client needs to the biological treatment. Okay. Now I want to make a conclusion about the exploratory model for you. For example, when you see your client and when you are uh, interviewing with your client, you have to understand that the root of your problem. And based on the theories about the depression in your mind, you have to recognize that how to interpret your client's depression. So, for example, when your client speaking about the relationship, it's better going to the John Bowlby. when your client speaking about unfair behavior, meaning that you have to refer to the Peter Levinson's theory. When your client is speaking about some learn hopelessness, meaning they are afford a lot and without outcome, they are living with the husband and they are doing a lot of things, but they don't receive any good feedback, meaning that you have to refer to the to this Martin Seligman theory called learn hopelessness. Just I want to get my message like this, based on the theories in the depression that I provide for you. And when you see the clients, you have to link between your client's problem with the theories. Then when you make a link between your client's problem and the theories, after that, you can provide a good treatment method for your client. Okay, this is too important because the base and the first stage of the you can provide a good treatment. What's the meaning of good diagnosis? Meaning that you have to understand your client's problem and you make a link between your client's problem with the theory. Okay. After that, based on the theory, you have to provide some treatments for your client. This is the map in my mind, and I would like to transfer my map to you. Okay. And for example, when you see your client has a biological problem, such as the low level of serotonin, dopamine, norepinephrine, so it's better refer your client to the psychiatrist to prescribe some medicine for your client. Okay, this is too important. Just let me now we want to enter to the depression and about the major diagnosis of depression. Let me inform you some statistics. During the life in the war, 20% of individuals experience of depression. Okay, and I think this is high rate in the world. 20% of individuals involved in depression during a lifetime. And the next one, the main, based on the WHO 2023, the leading and the main causes of disability in the world is depression. So we understand that depression is one of the biggest threat in the world. And in 2023, WHO announced that the leading causes of disability is depression. I think this is too important. We understand that depression is one of the leading problem, not leading mental problem, leading mental and physical problem. This is too important. Please, more attention to this. Okay, about the next, the rate of involving depression between female and male is 2-to-1, meaning that 2 female are depressed and 1 male are depressed. And this is the rate of depression between male and female. And the last one is the mean age of onset of depression is late of 20s. And the peak of depression is from 25 to 35. Okay? So I think this statistics is too important, and these statistics show that depression is one of the major global problem in the world, and we have to understand that we have to provide some treatment to reduce amount of the depression in the world. Now we want to speak about DSM-5, about the criteria and diagnosis of major depression disorder. Okay, 5 symptoms from the below list, 5 symptoms they're present during the same 2 weeks, but at least one must be A1 and A2. What is the A1 and A2? Depressed mode and anhedonia. You diagnosis person involved in depression. Okay? So I repeat it again. When you see 5 symptoms during 2 weeks, and one of the 5 must be A1 and A2. What is the A1 and A2? Depressed mode and anhedonia. Let me explain one by one to you. The first one is depressed mode. What is the meaning of depressed mode? When you see the individual with sadness, without energy, they are not happy, and they think that I don't have enough energy to do something, I'm sad, I don't be happy, I don't have motivation to do something, I'm sleeping on the bed from the morning to night, I don't have motivation going to work, I don't have motivation to see my children, to see my partner, meaning that individuals are involved in depression. The second one is anhedonia, meaning that your interest about the activity diminished and reduced relative to the past. For example, in the past, you did the exercise. In the past, you went to the cinema, to the theater, to the park, to see your family members, going to the gathering. But now, you dislike to do this. You don't have enough motivation going to see your family member. You don't have enough motivation to do the exercise. You don't have enough motivation to continue your work. You don't have enough motivation to continue your academic. So meaning that something in the past was very interesting for your client, but now it's not interesting for your client. Meaning that your client involves in anhedonia. And this is the second one. And the third one, weight and change. Do you remember when I spoke about hypocrites' melancholia, I told you that they discussed about eating food. Okay? Now you understand me. Individual major depression disorder with a feature of melancholy, please be careful about this. They are losing the weight. They don't have enough appetite for eating. They are not starving to eating. They're losing the weight. They don't have enough, starving to eat something. They lose the weight. But in atypical, major depression disorder with atypical feature, they are getting the weight. They gain the weight. They are eating more. So now you can make a link why I provide some histories about hypocrites, and now we want to link about the hypocrites theory with the current knowledge about the major depression. I think Hippocrates is very smart and genius because 2,400 years ago, he spoke about some characteristics of the depression. Nowadays, we are using about the knowledge about Hippocrates' knowledge related to 2,400 years ago. And the next one about insomnia and hypersomnia. Do you remember when I taught you about Hippocrates' theory, say that melancholic individual is sleeping low, atypical individual is sleeping high. You know that? See this one? Melancholic. In the melancholic, you know that there is low level of, that they lose the weight, early, they are waking up very, very soon, early morning awakening, for example, 2, 3 a.m. Or, significant anorexia or weight loss in melancholic. But, let me show you atypical getting weight. Let me, that often with carbohydrate craving, they are eating more. They are eating chocolate, they are eating rice or something like this. They are gaining weight. But most of them are depressed. But you have to understand and you have to discriminate between atypical features and melancholic features. So now I think you understand why I provide the Hippocrates theory and how make a link between the Hippocrates theory with the current knowledge about the depression. Okay, let me back to the symptoms. So insomnia and hypersomnia, meaning that they are sleeping more or they are awaking very soon, for example, 2 or 3 p.m., like melancholic features, depressed individual. And the next one, psychomotor agitation and psychomotor retardation. In severe depression, you see the psychomotor retardation. I'm so sorry, I'm gesturing for you. For example, when you are speaking with them, they are slowly movement. For example, like this. When they want to walking, when they are speaking, they are speaking loud, not slowly. You see the mental psychomotor retardation. Please be careful about it. You see the psychomotor retardation in severe depression, specifically in melancholy. They are speaking slowly. They are moving slowly. In the normal situation, you understand that the speed of the movement of individual. For example, now you understand that my speed of movement. But when I'm involved in the melancholy feature of depression, you understand that I'm speaking slowly. I move my head slowly like this. I move my hand, my foot slowly. You understand that the speed of the movement is a little bit slow. Okay? This is one of the symptoms. This is too important, specifically for melancholy or severe depression. Psychomotor agitation. And now do you remember I'm speaking about Martin Ross and Aubrey Ruiz about anxiety and depression? And I told you that one scientist believed that anxiety and depression is separated, and another one believed that anxiety and depression is, that combined together, because you see some people with anxiety, psychomotor agitation. They shaking the hand, they shaking the foot, like this, keeping the pen like this, doing like this, shaking the hand, the shaking the foot. They are involved in anxiety. They are involved in depression with an anxiety feature, with anxious feature. Do you understand me? Okay. And the next one is fatigue or lose of energy. The individual involved in depression doesn't have enough energy. Do you remember I told you in the melancholic individual, they aren't have enough energy to do anything. And the next one is feeling of worthlessness or guilt. As you remember, the melancholic individual feeling of guilt. and hypocrites mention about feeling of guilt in this individual. Okay. Now, the next one is diminished concentration. They don't have enough concentration. When they read the text, they read the paragraph, and I don't understand what did I read. I don't understand what I read already. I have to repeat it again. Maybe they are driving, they are thinking, where I'm going, I don't know. Let me thinking. Because they don't have enough concentration. Okay? This is one of the symptoms of depression. And then the last one, you know better than me, suicidal ideation. Individual involved in depression, one of the symptoms that you understand that individual involved in depression is suicidal ideation. Recurrent thinking of the death, recurrent thinking about suicidal ideation. Okay, let me conclude this section to you. There are 9 symptoms. And among the 9 symptoms, 5 symptoms must be present during 2 weeks. Among the 5 symptoms, one of the 2 symptoms must be inside the 5 symptoms. Then you can diagnose your client as a MDD, major depression disorder. Okay? Okay. Now, these are features of the depression, and in the next session, we are speaking about the specifiers or features of the depression and then treatment techniques. If you have any question, I'm at your service.
Okay, thank you, Dr. Abbas.
You are most
So your presentation is done, right?
for this session, yeah, it's done.
Okay.
I think we have to set the date and the time for the next session about the specifiers of the depression and treatment techniques.
Okay. So, jika ada pertanyaan, please raise your hand, or you can questions on chat. You can ask in Bahasa Indonesia or in English. I will translate it for you. Silakan. Oh, where's my? Silakan, teman-teman. Oh, okay, so we have one questions in the chat box. I will read it for you. Okay. Riza asked, he would like to ask that he is very interested in your lesson, especially when you explained Martin Seligman's and Peter Levinson's theories. While listening to your explanation, I tried to connect the ideas and make a conclusion from them. My question is whether that he is correct that his understanding that when someone learns helplessness and experiences only a few rewarding consequences in life, they may begin to understand that they should not depend entirely on their environment, but instead try to stay optimistic about their own decisions regardless of the consequences. And when they become aware of the lack of value of meaning in their lives, does it mean that the environment itself is not fully pressuring the person, but rather the person's interpretation and value lens toward the pressure from the environment? I think that's
Okay. You know that when we are speaking about the theories that explain the depression, meaning that we have to interpret the depression in my clients. You know that when you have a client, you have to make a link between the reason of the depression and the theory. So when you see someone going the effort in the environment and the environment doesn't provide positive feedback for the person, maybe the person is more likely involved in depression. So I think this is based on the theory. But we have to find some some positive factor or some protective factor in individual. When you see individual with the resiliency, when they see individual with the psychological hardiness, meaning that they are a protective factor for the individual, and they equip individual against of the negative consequences of the environment. But these are protective factor, and these variables such as resiliency and the psychological hardiness, they are a protective factor, and they are related to the positive psychology. And then in such situation, when you have a client receive the negative feedback from the environment, you have to improve some positive factor and protective factor in your client, such as resiliency, hardiness, optimistic, hope, or something like this. But these are theories, and these theories are trying to explain the depression in your client and or maybe in individual.
Thank you, Dr. Abbas.
Kiamat.
Riza, apakah bisa dipahami? Okay, thank you. Okay. So is there another questions from the students? Or while we wait, my students type their questions or try to compose their bravery to ask the questions. I probably, I think this question is more for me. In real world clinical settings, when a practitioner is working with a client and experiencing severe depression, is there a general rule of thumb on where to start first? For example, is it usually more effective to start behaviorally by scheduling rewarding activities to build a momentum, or should we address the distorted thought pattern first? I think it's regarding the intersection between using CBT and the cognitive structure, the cognitive restructuring in CBT, and Seligman's focus on restoring agency for depression. So what do you think? Is there any general rule of thumb where to start first?
Let me, I remember that the sentence from Ross Harris. Ross Harris is a pioneer of acceptance and commitment therapy. And this is a very popular sentence from Ross Harris. Ross Harris told that when you are at the shop and the client coming to request the refrigerator, you have to give the client refrigerator, not giving the client stuff, because the need of your client is refrigerator. When you have a client, based on the interview and based on the interview with your client, you understand that the reason of your client's problem, in my case, depression, you understand that the reason of your client's, then when you understand and diagnosis your client's problem, maybe the root of your client's depression is related to the environment, is related to the relationship, is related to the internal structure of the mind, is related to the reinforcement, is related to the biological problem. Maybe there is an imbalance between neurotransmitters. Okay, so when you understand that the reason and you diagnose the reason, based on the diagnosis, you have to provide the treatment, in my opinion, and I think based on the Ross Harris as a pioneer of the acceptance and commitment therapy. But there is a big mistake in some psychologists' mind. They say that, yes, I'm CBTist, I'm psychoanalyst, I'm DBTist, I'm emotional focused therapist, or something else. Then they are going to the treatment of the client based on the biased perspective. So they are living in own mind. They are not interviewing with the client. They are putting the lens in the eyes. They are putting the perspective lens. But we have to more focus on the client. First, we have to understand the client's problem. Based on understanding of the client's problem, then diagnosis, then provide the treatment.
So, do you think using only one paradigm or one perspective is actually kind of restrict the clients to have more comprehensive or more relevant treatment for their cases?
You know, maybe let me tell my sentence with an example. Maybe just you have one instrument and you say that I want to repair all cars by one instrument. I think this is impossible. You have to provide the variety of instruments. Then you can repair the car. When you say that just I want to following one perspective in psychology and I want to treat all patients and all clients with one perspective, I think this is dangerous.
Okay. Yeah.
Uh,
Yeah, I think most of the psychologists trapped in the perspective that he or she could only use a paradigm that suit to her preference or his preference. Okay.
you know, they can refer the clients to the expert in the perspective because maybe you can this sentence. There are several perspectives and paradigms in psychology. Maybe you cannot find a person expert in all paradigms. Yes, first we have to diagnose. When we understand that the problem, the client's problem, if we have a knowledge and we have an expert in the paradigm, we continue with the client. If we don't have enough knowledge or we are not expert, we have to refer to the expert. So, but first we have to diagnosis. If you are expert, for example, in the client's problems, then you can continue with the client. If you don't have enough experience or enough knowledge about the specific paradigm or perspective, so it's reasonable to refer to the expert. But in my opinion, it's better the psychologist expert in some perspectives and paradigms
Okay.
rather than one perspective.
Oke, ayo teman-teman, ada pertanyaan lain barangkali, silakan. Kalau dalam bahasa Indonesia juga tidak apa-apa. Ya, nanti saya akan bantu untuk translasikan atau ketik di chat room gitu. Nanti saya akan bacakan dan translasikan. So there's this one questions. It's privately direct to me, and it's regarding the John Bowlby's theory. And how do you see a person's early attachment history directly shaping their adult cognitive triad? In your view, does healing the attachment security automatically fix those negative cognitive lenses?
When we are speaking about attachment, we are speaking about the trust between the care and caregiver. You know that when they are trust together. For example, when you see the inborn or infant children, if they are hungry, the caregiver, like mother, provide some food for the children or something like this, meaning that this baby learns how to trust to the environment. But when the mother showing the ambivalence behavior, sometimes provide, sometimes doesn't provide, the baby learns the environment is not safe and trustable. So saying that in the future, if I'm hungry, are there anyone to feed me or not? Meaning that individual thinking about anxious attachment, because they are receiving the ambivalent services from the take care person, such as mother. But I think this is too important. We have to provide the good sense of belonging between in children, because when they are feeling of sense of belonging and they understand that the environment is a safe place, they are less likely involved in unsecure attachment styles.
Okay. Okay, thank you, Dr. Abbas. There's this one question. I don't know why my students chat me privately. I think they're shy. And do you mention, sorry, you mentioned that one of the symptoms of, oh, okay, so I think I will give this session to Raisa first. Raisa, please, silakan.
Good afternoon, Dr. Abbas and everyone. I am sorry for intruding in this classroom. I am actually not a student in this classroom. I got this link from Mrs. Fadila, a psychology lecturer from Bandung Institute of Technology. I am a designer and currently preparing a research proposal for my master's degree, specifically in media design as a therapy tool for depression. My question is, would it be possible to train people from the learned helplessness perspective to unlearn it and reward them with each development they do for themselves, possibly with a dopamine boost from a mobile game or application who requires the users to do real-life tasks as an in-game currency?
Yeah, but thank you so much for you and for participating in this workshop. If I want to answer to you, because when we are speaking about the application, we have to take about everything and we have to provide the comprehensive assessment and evaluation of the some applications. But when when you understand that the people is effort allow and the people don't have a control of the output and the result, you understand that these people is disposition to involve in depression. Okay, but you have to provide the balance between effort and the outcome and the reward. If there is a mismatch between effort and outcome, you cannot treat individual from learned hopelessness. Okay, maybe you want to design a program in the application and using the virtual space for treatment. Yes, you can do this, but you have to consider other side effects of the application, because virtual space is different from real space. You know that this is a different story. But if I want to explain the theory, I'm saying that you have to provide the balance between effort and reward. If there is an imbalance between effort and reward, you can estimate that individual involved in depression. But about designing the application in virtual space and you improve the behavior of individual in the real space, you have to be careful and you have to consider other negative factors in the virtual space. In my opinion, when you provide some treatment, like the some treatment, not all treatments, some treatments, the person, specifically the children, are working with the virtual space. They are learning to be impatient, because when do something, when effort, and immediately they are waiting for the result. For example, you are playing the match, and after 10 minutes, you will get the result. You are a winner or loser, okay? But in the real world, the story is totally different. In the real world, you have to afford a lot. Maybe after 1 year, 2 years, after 3 years, you get the result. Because we have to careful about the patient and impatient. Based on my experience, some treatments are not useful using the virtual space, because virtual space doesn't learn to the children to be patient.
I see.
Okay.
Thank
But
you, Dr. Abbas.
You're
yeah,
most
I think Mbak Raisa should join the next session regarding the treatment and intervention for depression, so she can develop her thesis more accurate to the needs of people with depression. So I think this is one last questions. Where it is. Okay. So you mentioned that one of the symptom of depression is a lack of concentration. But how about I often read that someone could be high functioning but depression at the same time, as it happened to one famous author, J.K. Rowling, that she diagnosed she has depression diagnosis, but at the same time she could write Harry Potter, and it's considered as a masterpiece. So what do you think about it, Dr. Abbas?
we cannot say the causal relationship between depression and lack of concentration, because this is one of the symptoms, okay? Because you see in some depressed individual low level of concentration, and in some depressed individual high level of concentration. Because I remember that I don't remember the name of the scientist, but the scientist told that the depressed individual is the backbone of the society. This is a big sentence saying that some depressed individual, specifically some dysthymia, individual involved in dysthymia, they are working very hard, they are very smart, they are very intelligent and very genuine, but they are involved in depression. We cannot say that there is a causal relationship with depressed individual and low level of concentration. But this is one of the symptoms. As I told you, one symptom of the depression could be low level of concentration. But we cannot say there is a causal relationship, because I have seen several depressed individuals with intelligent, with genius, with more focus on the work, and we cannot say that there is a causal relationship between them. But in one feature, as I explained about the Martin Ross and Aubrey Lewis, because one of the feature of anxiety, one of the symptom of anxiety is low level of concentration. Do you remember? Because I choose Aubrey Lewis and Martin Ross because they are against together, because one of them believe that the anxiety and depression is separated, one of them believe that anxiety and depression are combined together. But the low level of concentration is more likely to see in depressed individual with anxious feature, and the depressed individual with anxious feature are more likely to have a concentration problem rather than maybe melancholic individual or mixed individual.
Okay, thank you, Dr. Abbas. I think time is up. We already passed 15 minutes. So
Okay.
yeah, thank you, Dr. Abbas. This has been an incredibly enlightening session, and I hope my students can, in the next session, have bravery to ask you directly. But this has been an incredibly enlightening session, and your expertise in depression specifically has given us much clearer perspective on the complexities of depression. And before we sign off, I would like to thanks everyone on the behalf of the Department of Psychology. And we thank Dr. Abbas Abdollahi for his time and brilliant insights. And thank you for all the participants for your active engagement. And stay safe, everyone, and have a wonderful day. So thank you.
Thank you so much. Thank you so much for you and for all your colleagues to arrange this meeting for me. And I appreciate all audience and all participants in this workshop. I hope that the workshop is being useful for all of them. I appreciate all of you. Thank you so much. Have a good day.
Thank you so much. Thank you, Dr. Abbas. Teman-teman silakan isi presensi. Ya, you can leave. Ya, bye. Bye. Ya, teman-teman silakan diisi presensinya yang sudah di-share oleh Beni ya. Terima kasih sekali atas kehadirannya hari ini. Saya tutup sekali lagi gitu ya. Selamat siang. Assalamualaikum warahmatullahi wabarakatuh.